Welcome back to the deep dive. I hope you're ready to stretch your brain a little bit today because we are zooming out.
Way out.
Way, way out. Usually when we talk about health, we think of it as this incredibly personal thing.
A lonely battle, almost.
Exactly. It's you versus the flu. It's you versus your cholesterol. You go to the doctor, they check your blood pressure, critique your diet.
And give you a pill.
Huh.
It's what we call the medical model. A broken part in a machine that needs fixing.
Right. Very biological, very individual. It assumes the problem. And the solution begins and ends with the person sitting on that exam table.
But the stack of research we have today basically says that view is, well, it's woefully incomplete.
It suggests that a community can be a patient just as much as a person can.
And more importantly, if you ignore the community, you might be completely wasting your time trying to treat the person.
That's a huge shift in perspective.
It is. We're diving into the world of public health nursing, but, don't let the job title fool you. This isn't just about vaccines and bandages. We're looking at the architecture of how wellness actually happens. It's less about treating sickness once it's raging and more about engineering an environment.
And a mindset.
And a mindset where that sickness just doesn't have a chance to take root.
I love that phrase, engineering an environment. The term that really stuck with me from the reading was describing these nurses as change agents, which honestly sounds like a covert op, like something from a spy movie.
In a way, it kind of is.
Right, I'm a change agent.
Because you're trying to change things that people often don't even notice are influencing them. So we've got two huge themes to unpack today.
Okay.
One is health promotion through education, which is the fascinating psychology of how we learn and why it's so hard to change.
And the other?
The other is community as client, which is how you assess and treat an entire population as if it were a single living organism.
And these two aren't separate tracks, right? They seem pretty jammed together.
They're deeply intertwined. You absolutely cannot treat a community without understanding the individual psychology of the people inside it.
And vice versa.
And vice versa. You can't expect an individual to change if you ignore the community conditions they wake up to every single morning.
So let's start there, with those conditions. Because the research leads with this concept of the social determinants of health.
SDOH for short.
It sounds a bit academic, but when you dig into it, man, it explains a lot about why willpower alone just isn't enough.
It really does. The World Health Organization defines them as the conditions in which people are born, grow, live, work, and age.
Which is, well, that's everything. That's your whole life.
Essentially, yes.
Yeah.
It's your zip code. It's your job stability. It's the air you breathe. It's whether you have a car or have to wait 2 hours for a bus.
And the data says these factors have a massive impact.
Often a bigger impact than your genetics or even your access to a hospital.
There is one study in the notes that really it blew my mind. It felt like the smoking gun for this whole argument, the Whitehall studies.
Ah, yes. The classic Whitehall studies. If you want to understand the social ladder and health, that's where you start.
So for anyone who hasn't heard of this, they studied British civil servants. And the key here is that this is in the UK, so they have the National Health Service.
Right. So theoretically, everyone in this study, from the top executive to the mailroom clerk, had access to the same doctors and the same care.
The financial barrier was removed?
Correct. That's the variable they controlled for.
So you'd think, okay, level playing field. Health outcomes should be roughly equal.
But they weren't. Not even close.
What did they find?
They found a stark, perfect gradient. They called it the socioeconomic gradient in health. Those at the very top of the hierarchy had the best health.
And as you went down?
As you went down the ladder, rung by rung, health got progressively worse. Mortality rates went up. Heart disease went up. Everything.
But wait, did they account for the usual suspects? Like maybe the lower level employees just smoked more or ate worse?
That's the first question everyone asks. And yes, they did. Even when the researchers controlled for things like diet, smoking, and exercise, the gradient was still there.
That's wild to me.
It is.
It suggests that status itself, that feeling of where you fit in, the lack of control over your day, that actually gets under your skin and affects your biology?
It does. It's about chronic stress. The stress of being lower on that ladder, of having less autonomy, it creates a physiological wear and tear.
And this connects directly to health disparities.
Exactly. These preventable differences in the burden of disease. And the source material highlights some really stark numbers in the U.S.
Like life expectancy being lower in African-American populations and rural communities.
And infant mortality. It's significantly higher for Black infants than for white infants.
And the text is really clear. We can't just explain this away by saying, oh, people are making bad choices.
No, that's the trap. These are upstream factors. Think about it. If you live in a food desert.
A neighborhood with no grocery stores, just gas stations and fast food.
Right. Then your choice to eat a healthy salad is, well, it's severely restricted.
Or if a nurse tells a patient, you need to walk 30 minutes a day, but the patient lives in a neighborhood with broken sidewalks and no streetlights.
Then you've given them an impossible task. If the environment fights the behavior, the environment usually wins.
So this is where it gets tricky for our change agent. You have to acknowledge the tough environment, but you still have to help people change.
Exactly. You acknowledge the barrier, but you don't accept defeat. And that requires a deep understanding of the psychology of change.
How humans actually adapt. This is where we get into change theory. And the material distinguishes between two types, evolutionary and revolutionary.
Right. Evolutionary is gradual. It's modifying what you already do. I smoke a pack a day. Next week, I'll smoke half a pack.
Incremental. It feels safer, like dipping your toe in the pool.
It is safer. It doesn't require a whole new identity. But then there's revolutionary change.
Which sounds intense.
It is. It's drastic. It's sudden. And it's usually forced on you because the status quo just got shattered.
A heart attack.
A heart attack, a sudden job loss, a natural disaster. You don't have the luxury of gradual. You have to pivot immediately.
And to navigate either of those, the text brings up Kurt Lewin's three-step model: unfreezing, changing, and refreezing.
A cornerstone of change theory. Step one is unfreezing. This is key. Habits are like ice blocks. You can't reshape them while they're frozen solid.
You have to melt the status quo. This is the wake-up call.
Exactly. The denial breaks. Then comes step two, changing or moving. This is the messy middle.
Oh, the messy middle. I know this place.
We all do. You've unfrozen the old habit, but the new one isn't solid yet. You're trying to manage stress without a cigarette. Feels awkward. You feel incompetent.
This is where most people quit.
It is the danger zone. But if you push through, you get to step three, refreezing.
The new behavior becomes the new normal.
It stabilizes. You don't even have to think about it anymore. It's just who you are now.
But let's be real. And the text acknowledges this. We aren't robots. I've unfrozen my diet plans about 50 times and refrozen right back to pizza.
Which is very human.
Right.
And that's where the trans-theoretical model, or TTM, comes in. It sees change not as a line, but as a spiral.
A spiral?
Yeah, it acknowledges that we cycle through stages and that relapse is often just part of the process.
Wait, let's break down those stages because they explain so much. The first is pre-contemplation.
This is the stage of denial. The person isn't even thinking about changing. They'll say something like, my grandpa smoked till he was 90. They just tune you out.
They don't even see a problem, so they're not even on the game board yet.
Exactly. Then you have contemplation. This is the I know I should, but stage.
The land of ambivalence. I know I should quit, but work is so stressful right now.
Precisely. Awareness, but no commitment. Then comes preparation.
Buying the patch, looking up gym prices.
Right. Then action, actually doing the new behavior. And finally, maintenance, keeping it up and preventing relapse.
And the key insight here for a nurse, or anyone really, is that your response has to match their stage.
Absolutely. If your friend is in pre-contemplation, total denial, buying them a gym membership for their birthday is a waste of money.
Because that's an action step.
It's an action step. You're trying to force them to a stage they haven't reached.
Uh-huh.
For someone in pre-contemplation, your only goal is to gently raise awareness. Plant a seed.
Meet them where they are.
You have to meet them where they are.
Okay, so let's say we've met them. They're ready to learn. The notes break learning down into 3 domains, and I feel like school only ever focuses on one of them.
Usually the cognitive domain, the thinking part. Recall, comprehension. If a patient can explain how insulin works, they've achieved cognitive learning.
They get an A on the test.
But knowing the facts doesn't mean they can do the task. That's the psychomotor domain. Physical skills.
And for that, the text says you need 3 things. Capability.
Are they physically able? Do they have the dexterity?
A sensory image.
They need to see what it looks like. Yeah. This is why YouTube tutorials have taken over the world. You need that mental picture.
I can't read a manual. I have to watch someone do it.
Exactly. And the third thing is practice. You have to build that muscle memory.
But then there's the third domain. And this one seems like the hardest by a mile. The affective domain.
It is the hardest. It deals with feelings, values, attitudes. You can know how insulin works, and you can know how to inject it. But if you don't value your health,
you just won't do it.
You won't do it. Effective learning is about internalizing a value, so that it actually controls your behavior.
That feels like the true heavy lifting of being a change agent. You're not just transferring data, you're trying to shift someone's values.
And that requires trust. You can't lecture someone into changing their values. You have to listen first.
Okay, so we've looked at the individual's brain, how they learn. Now let's zoom that lens back out to the community as client.
The aggregate.
Right. And one of the best tools for this, and I love how analog it is the windshield survey.
I love the name too.
It's literally just driving around and looking out the windshield.
It is. It's collecting primary data through direct observation. You get in your car or you walk the streets. You engage your senses.
But you're looking for specific clues, right? Are the buildings in good repair? Are there stray animals?
Who's on the street corners? What are the billboards advertising? If you see billboards for payday loans and alcohol, that tells you something about the economic stress.
If you see bars on the windows of homes,
that tells you about the residents' perception of safety. It grounds the data in reality.
So, say your spreadsheet says high obesity rates. Your first thought is, let's hold a jogging class.
But then you do a windshield survey. And you see the sidewalks are cracked, there are stray dogs, and there are no streetlights.
Suddenly your jogging class idea looks ridiculous.
It looks unsafe and totally tone deaf. The survey prevents you from making assumptions that don't fit the reality of people's lives.
Now, when assessing a community, the text mentioned a really optimistic approach called assets assessment.
Yes, it's a crucial shift from a pathology model to a strengths model.
So instead of asking, what's wrong here?
You ask, what's right here? What can we build on? Maybe there's a really active church network or a trusted local barbershop.
You're looking for the heroes that are already there.
Precisely. You build on strengths, you treat the community as a partner, not as a helpless victim.
So after all that, you actually write a community diagnosis.
Yes, and they follow a specific structure. Risk of problem among group related to cause.
The example was, any town, Kansas, experiencing increased crime related to inadequate law enforcement.
And rapid population growth.
And inadequate law enforcement isn't a medical issue, but you're saying it's a public health issue.
Absolutely. Because crime affects stress levels, it affects physical safety, it affects everything.
Then you plan using SMART objectives.
Specific, measurable, achievable, realistic, and time-bound.
It's the universal language of getting stuff done.
It is. A goal is fuzzy. Reduce crime. An objective is tactical. By month 6, reduce reported assaults by 10%. You need a number and a deadline.
Otherwise, how do you know if you succeeded? Which brings us to the final piece, evaluation.
Which breaks down into 2 types.
Formative and summative. I liked the cooking analogy they used here.
It's the best way to remember it. Formative evaluation is tasting the soup while you're cooking it.
The stove is still on. You taste it and think.
Needs more salt. The program, you ask, are people showing up? Is the brochure confusing? You fix the process as you go.
And summative.
That's tasting the soup at the end. Did the guests like it? It's the final outcome. Did crime actually go down by 10%?
It seems like this whole journey from change theory to the windshield survey is all driving toward one word: empowerment.
That is the synthesis. The goal isn't just to fix it for them, it's to equip them.
Self-care.
Self-care and community competence. The nurse is a partner, not a savior. You want to work yourself out of a job.
So it's a shift from being a mechanic, fixing broken parts, to being a gardener.
That's a beautiful way to put it. You're trying to fix the soil so the plants can grow on their own.
Before we wrap up, I want to leave the listener with a thought that's been nagging at me since we started talking about those upstream factors. We place so much weight on personal responsibility in our culture. Eat right, exercise, grind harder.
You tend to moralize health. If you're sick, it must be because you did something wrong.
But this research suggests a huge chunk of our choices are made for us before we even wake up in the morning. By our zip code, by our job.
It raises a tough question. How much of your health is truly a reflection of your willpower?
And how much is just a mirror reflecting the environment you've been placed in?
Something to chew on.
And maybe do your own little windshield survey next time you're driving through your neighborhood. See what you notice.
When you really look.
Thanks for diving deep with us today.
Stay curious.